Everyone. So we move on to the next session, which is corneal tattooing when science meets aesthetics. This session was supposed to be hosted by Dr. Kunjal, who is not able to make it today due to some unavoidable circumstances. So as we all know that tattooing is for improving the cosmesis aesthetics part of the eye, and not only the cosmesis, it helps in boosting confidence in patients who have been suffering from the social stigma of white eye. So we begin the session with the topic of indications and dye used for corneal tattooing by Dr. Aditi Johari.
A very good evening to everybody here. Thanks to AIOS for including this course. And a round of applause for all of you, because you are the true audience for corneal tattooing who will never give up till the end. So corneal tattooing is that procedure, and you are the perfect audience. Okay, so I will begin with the indications and the types of dye used for corneal tattooing. Cosmetics is important today, just as it has always been historically also, but more so now when a cosmetic defect in the eye is unacceptable and limits the quality of life in many patients. So when there is no hope of getting vision in that eye, at least there should be hope for aesthetics, and that will soften the blow in delivering the message to the patient. I will be speaking on the history of keratopigmentation or corneal tattooing, the indications, the contraindications, and the types of dye. The rest of the topics will be covered subsequently by the other speakers. It is nice to know a little bit of historical perspective, because we should know at least the names of the giants on whose shoulders we stand. So the Roman physician, the ancient Roman physician Galen, was the first doctor, the first physician who performed the first corneal tattooing in human history. He used, for unsightly corneal scarring, he used something called a pomegranate bark, and he covered the cornea with that bark to provide the tattooing. Several centuries, nothing was done, and after that came Dr. Samuel Ziegler. He is considered the father of modern keratopigmentation, and it is his protocols that we have built up on today. So he did an exhaustive body of work, and he actually wrote a book, Multicolor Tattooing of the Cornea, in which he has described not only the types of pigments, he has given exhaustive thesis on the types of colors which should be used, what mixed with what, the blue mixed with green gives a brown, and how much the pupil size should be. So he had done a huge body of work, and much of our keratopigmentation techniques now come from what we have developed upon that science. Much later, the oculoplastic surgeons, these are all names of people in history who have experimented with corneal tattooing. So Wecker's needle was a needle in which cocaine was used to anesthetize the eye, then a dye was spread on the cornea, and then it was embedded with the single, like you can see, there's a single stylet. So this was the Wecker's needle. Much later, Dr. Taylor decided that a bunch of needles was more efficient than a single needle. So in fact, that is the basis for the tattoo gun, which will also be described later by Dr. Mona. Then came other authors, von Hippels, then came other instruments. Slowly, by little, this procedure has evolved. So they made a dye, so they made a tubular tiftrifine to localize the dye onto the cornea, and then used a fountain pen or an electric needle to drive the dye into the cornea. So keratopigmentation has now been established as a safe surgical procedure that is easy to learn, easy to perform, does not require a lot of specialized instruments, and it avoids the extensive and invasive reconstructive ocular procedures like evisceration, enucleation that have to be done to provide cosmesis. So it is a kind of a semi-non-invasive kind of procedure. Corneal tattooing can be a procedure for long-term or permanent correction of cosmetic eye deformities in patients who suffer from scars like this. Now, what is the advantage or disadvantages? How does it compare with the cosmetic lens? Because these are the options that we provide to a patient when he presents for cosmesis. So we tell them you can use a prosthetic contact lens, but the problem with that is, till you're using it, you have the cosmesis. And when you take it off, it is white again. So in contrast, tattooing gives you a more permanent kind of solution. So with contact lenses, there is always an issue of hygiene and compliance issues, but with tattooing, there is no problem, there is no maintenance, because once it is done, it is done. You may need to repeat it in the future, but nothing on a daily basis. So as far as the indications go, it is very important to consider which cases are amenable, because case selection is what is important. So indications are divided into cosmetic indications and functional indications. So if there's something wrong with the cornea per se, if there is a corneal scar without anterior synechiae, mind it. If there is an adherent glaucoma without the iris peeking out, if there is cicatricial keratitis, or if the patient is just not willing for the daily hassle of cosmetic contact lens wear, then you go in for corneal tattooing. Then if there is a retrocorneal pathology, like the pupil is white, there is leukocoria, it's an end stage eye, there is no visual potential, but the eye is white, the girl is getting married, she wants cosmesis. So then tattooing is an option. And then if there are iris defects, iridia, then there is the coloboma, there is essential iris atrophy in which the glare is coming out and the patient wants relief from that, or it's causing some kind of shadowing or discomfort, then iris problems are also a reason to go ahead with tattooing. Recently, Dr. Halio, who has done extensive work on corneal tattooing, has also described a cosmetic indication. So this may be slightly controversial, but he has done it, and he has proven that purely cosmetic keratopigmentation has demonstrated stable long-term follow-up with no visual disability, high patient satisfaction, and favorable outcomes in all patients. So this should be offered to patients who want it just for cosmetic. It is a seeing eye, but you want it for cosmesis. Contraindications are when you should not do the procedure. This is what I was speaking about, case selection. If there is a leaking cicatrix, then you know that your dye is never going to stay there. It is going to fade away. It is going to get washed away as it gets diluted by the tears. So if there is a synechia, if there is active inflammation in the eye, if there is iridocyclitis, if there is intractable inflammation, then the dye kind of gets phagocytosed by the corneal stroma, by the keratocyte, so it will fade away quickly. So there is no point in doing it repetitively again and again. If there is intractable glaucoma and that causes persistent corneal edema, that will also cause a loosening of the corneal epithelium. So the epithelium will keep breaking down and the patient will be as miserable as when he had presented to you. So the types of dye, even though it is true that since Gallen's time pigmentation has been known, it is now only that extensive research has been done on the type of modern dyes and pigments that can be tolerated by the eye and that give you a good cosmetic outcome. Again, if we go back historically to Ziegler, the pigments, he gave the characteristics of an ideal dye. So it should be able to mask intercept the light which is coming, it should be able to obscure the corneal scar. Mineral colors are more permanent than vegetable colors. Irritating pigments should not be deployed. So we have built upon that and we have categorized the modern pigments into 3 types. The first generation are the skin pigments which you use for your skin tattooing, either the liquid type or the powder type. The second generation are non-certified pigments and the third generation are cornea-specific pigments. So Dr. Ziegler had come up with a surgical protocol. So he had described that it is important, you're doing this for cosmesis. So it is important to match as much as possible the color of the tattooed eye to that of the healthy eye. So people have gone into really great detail and they have described what should be the size of the pupil, what should be the color of the iris surrounding it, the color of the striations in the iris. So that gives you a perfect cosmetic match with the other eye. And pigments which should be avoided are obviously the ones which cause irritation on the eye, such as cadmium, cobalt, and the ones which have a high rate of addition of chemical excipients. Disadvantages of the traditional metallic salts are that they are irritative to the eye, so they cause recurrent corneal erosions, corneal redness, and melt, and they fade away, so you need to repeat the procedure again and again. So this is where the micronized mineral pigments come into play, because the metallic ones don't stay for so long. So once you kind of break down the size into very small particle size, 2.5 microns or less, then this can be driven into the stoma and it will stay there for a reasonable length of time. Another important advantage with these micronized pigments is that you get them in several colors, so you can mix them and get a whole array of colors to match the iris of match the color of the other eye. And it has been demonstrated that several studies have demonstrated that the corneal tolerance to these micronized inorganic pigments is quite good, and there are no inflammatory reactions. There were no kind of adverse reactions on the epithelium or the stroma. And even though the dye, in fact, they have shown that it stayed for 25 years or so within the keratocytes, and it caused no harm. As far as commercially available dyes go, you have Dr. Mahatme's powder, which was used, and the second is the India ink, which will be described later for use with the tattoo gun. And the third type which has been shown is the traditional type of soot powder, which is made in the operation theater by inverting a steel bowl onto a candle. So you build up a soot, and it is a kind of a homegrown measure to use it for disfiguring corneal opacities. So so you have these two types of dyes. Basically, one causes the chemical staining, which means that you use metallic dyes like the gold chloride, silver nitrate, and the platinum chloride. So as long as you get your dilutions right between 2 to 5%, you can use these pigments, and you can put hydrazine as a fixative, and this will give you, and you can play around with the match of the colors to give you the exact color which you want. And that will stay on the surface, and you can refrigerate these pigments and reconstitute them with distilled water. So whenever you need them, you autoclave it, bring it to the OT, and use this. These are the metallic dyes. And like I told you, they don't stay there for too long. The non-metallic dyes are the ones which are being used currently, India ink and titanium dioxide and all. And histopathology has shown that they stay in the intracellular, they stay in the keratocytes for a very long time. Other aspects to consider before you actually do the procedure is that all the contraindications should be taken care of. If there is an adherent leukoma and iris is stuck there, then a synechiectomy is suggested. If there is conjunctivitis, you take care of that. If there is an NLDO or lacrimal duct obstruction, then you need to do the probing and syringing before that. If there is phthisis bulbi, that is a kind of a relative contraindication because the eye is in a kind of anophthalmic position. So they have described that you do a tenotomy of all the recti muscles and kind of make a compensating exophthalmos so that your eye comes out of the socket, and then you tattoo that. So extensive procedure, but it has been described. Most important is counseling. Counseling, like for every other procedure in ophthalmology, if the patient understands the advantages of what he is going in for, he is more likely to be compliant with the follow-up and understand that it may need to be required to be done again. And as far as the slit lamp examination and all goes, you need to measure you need to confirm the lack of visual acuity. The intraocular pressure should be within normal limits. And ASOCT we have described because you need to know if there are any areas of focal thinning. If there is an area of focal thinning and you go in with a tattoo gun, which is puncturing, you will enter the chamber and you will inject your dye inside. So these are the investigations which need to be done. So we can conclude that keratopigmentation achieves stable and satisfactory cosmetic results with very high patient satisfaction. Based on this idea, this systematic approach has been developed in the last 10 years mostly, so that what was an empirical thing earlier has now become an art and a science. So there has been great improvement in the surgical techniques. So we have much reliable, very advanced instruments now that deliver very consistent results, and there is high patient satisfaction. The complications which will be described, and like every procedure there are complications, they are likely related to the learning curve and mostly related to the patient selection. If you choose the patient in which you are doing this procedure correctly, then you will end up with less nightmares. And these are some of the results which will be shown later also. So, thank you.
Thanks, Dr. Aditi, for such an exhaustive talk. Now, I would like to invite Dr. Aditya Pradhan for his presentation on lamellar pocket and surface pigmentation techniques, as well as his innovations for this technique.
Yeah, good evening and thank you all for attending. Thank you Dr. Kunjal and scientific committee for this opportunity. So as she won't be able to attend, I'll be covering her talk and then covering my talk subsequently. So basically this will be a overview of the different techniques to achieve a corneal tattooing. So we have learned from the previous speaker that when to do it, when not to do it. So that is the probably the most important thing to do before any kind of ocular surgery. So with that we will learn about the lamellar pocket and the surface pigmentation techniques. So like madam has already mentioned, please do not touch such type of eyes. So basically heavily vascularized corneas, eyes with intractable secondary glaucomas, anterior staphylomas, eyes which are already thusical. It's best that we try some other method of achieving cosmesis rather than doing a tattooing. So we have different techniques to achieve a tattooing of the surface. We have the chemical method of Galen or NAP, in which we are using the gold and the platinum salts. So the coloring method, that is basically we have carbon soot or India ink, and we have the tattoo dye. The powder is not easily available. We can use the liquid tattoo ink instead. So we can have a superficial tattooing which is achieved with the pigments. We have the transepithelial intrastromal micropuncture with the powder or the soot, which is not a preferred technique. You can make a lamellar pocket and then put the soot or the powder or the liquid dye into it, and you can use the tattoo gun, which is automated way to achieve the stromal micropunctures and use the liquid dye. So if you go to the lamellar pocket, we can achieve this pocket. You can create it by hand, just fashion it out with a crescent or a lamellar dissecting blade. You can use a microkeratome or you can use a femtosecond laser, which is quite fancy. So we are not covering this in the instruction course. Or you can, and to achieve this into the pocket, you can put the soot or the liquid dye or the India ink. But the caveat here is, if the scar is full thickness, you can construct a pocket, but there will always be the roof of the pocket which has the white opacity in it. So that again, to cover that, you have to do either a stromal micropuncture or use the gold and the platinum salts. So the pocket is, since the pigments are not exposed to the surface, the advantages are longer retention and less risk of recurrent erosions. So I'll just show you a video. So as you can see, there is this full thickness scar, and the surgeon is fashioning a lamellar pocket with a lamellar dissector above the level of the but obviously some part will still be visible, and now the powder is being pushed into the lamellar pocket to achieve the desired cosmesis. So here the depth of the dissection is extremely important. One should not go too deep, or just to avoid any perforation into the anterior chamber, and the roof of the pocket is being tackled with and the suture is being applied. The suture, you can put a bandage contact lens for better comfort. So this is basically a 30-year-old male who underwent VR surgery. So this is the result 6 weeks post-op with the powder, which was pushed into the lamellar pocket. So this again soot, as madam has showed, you can improvise it in the OT by using a candle. So this again, this eye was highly disfigured, and for cosmetic reasons, this was the outcome. So again, this was status post VR surgery, a non-seeing eye. So with the liquid dye, this is the result 4 months post-operatively. The other option you can have is using the reaction between the gold and the platinum chloride. The gold chloride gives a brownish color to the eye, and the platinum chloride gives a blackish color. You have to reconstitute in distilled water and refrigerate, and then autoclave the color before use. 2% hydrazine hydrate is used as a fixative. Both are applied each for a minute after you remove the epithelium from the cornea. Availability is always a concern, but this is definitely one of the methods you can use. So basically the precipitate, because of the reaction between the fixative, that is the hydrazine and the salts, the metallic precipitate is deposited into the keratocytes and between the stromal lamellae, and it's an easy and quick procedure. But yes, definitely, as madam has mentioned before, they are irritant to the ocular surface and can lead to recurrent erosions. You have to wash off the fixative because it is very toxic to the ocular surface. So this video demonstrates the use of the epithelium is being scraped up, and now by using a well so that the pigments don't spread elsewhere on the surface, this is being applied, and you can see this is a quick reaction which gives a color on the spot, this black color. And then after leaving it for a while, you can just wash it off. So you can mix and match so that it goes well with the color of the other eye. For Indian eyes, it's quite easy because they are heavily pigmented. For Caucasian eyes, it's a challenge to get the accurate shade. So the post-operative regimen in these procedures, basically you remove the B cell after a month. You give copious topical lubricants, topical antibiotics, cycloplegics, and once the epithelial defect is healed, maybe after the third or the fourth day, you start them on low-dose steroids and taper them over a longer period. And sometimes if the patient complains of pain, you can add oral NSAIDs. So this is again a lady who was blinded post VR surgery. So this is after 18 months. Upon close examination on the slit lamp, you can see the mix of the gold and the black color, but from a distance, it all appears cosmetically acceptable. This was the pre-op photo. This is again status post VR surgery. This is 12 weeks, that is 3 months post-op. This is another photo of a patient who was having this leukomatous scar, which is covered by the pigment. So basically, tattooing is an excellent cosmetic option for disfigured eyes. We are evolving with better and newer techniques every day, but like any other surgery, a lot of repeated counseling is required both for the patient and the attender of the patient. Sometimes it's not the patient but the attenders who cause the most trouble in the outdoor. So basically you have to call them for repeated sessions, counsel them at each visit, and only when they are convinced about the utility of the procedure, only then you should move ahead with this. And the probability of a repeat tattooing should always be emphasized at each counseling, because nothing is permanent, so is this color, everything fades with time. So you have to keep counseling them and tell them ki yes, we can, it's a repeatable procedure. If it fades away, we can always repeat the procedure for you. And certain contraindications, as mentioned earlier, simply do not touch such eyes. Thank you. Now, till now, we have been discussing eyes which are essentially blind, either due to trauma or post intraocular surgery, or they are congenitally blind. So now, in this next presentation, I aim to present something in which Madam has showed the indications, that is reduction of glare and photophobia is one of the objectives why we do tattooing. But obviously one has to be very careful. So I'll just go into slideshow. Yeah. So I have no financial interest to disclose. So I'll just start with the video. I think everybody can follow what is going on. Thank you. Mike.
I am going to present on tattoo using tattoo gun, which was also innovated by Aditya actually. So coming to some pre-operative checks, which includes the visual acuity, intraocular pressure measurements, anterior segment photograph for the exact overall cosmetic appearance after surgery, the limbal health, presence of clock hours of vascularization. ASOCT is very important to demarcate the area of thinning, as Dr. Aditi has already mentioned, and we will see in the subsequent video. The posterior segment status, the consent for the procedure is of utmost importance. Then chances of fading needs to be explained to the patient once and again, because it does happens and one needs to repeat the procedure post-op again in the post-op period. So these are the overall components of the tattoo gun: the adapter, cable, switch, the handles, multiple needles, speed can be adjusted, as well as the depth. The technique, it's a useful technique for basically anterior stromal scars. Their automated micro punches are performed involving the superficial layers of the stroma up to a depth of 2.5 millimeters from the corneal surface. And the penetration depth of the needle is controlled by the length of the longitudinal axial vibration of the tip. And there are different tips and needles available depending on the area that is going to be treated. Speed can be kept in a medium range, and a micro drop of stain is sufficient enough over the corneal surface, followed by micro punctures which are performed down to the superficial layers of the cornea depending on the depth of the scar. And the procedure is repeated after multiple washes until adequate amount of pigment is introduced into the superficial cornea to achieve a acceptable cosmetic appearance. Some of the intraoperative measures are selection of the depth of penetration of the needle depending on the depth of scar, areas of thinning to be demarcated to avoid perforation intraoperatively. Automated micropunctures are performed during the procedure. Less than a drop of dye is sufficient enough to cover the entire surface for one round, as the excess dye would get washed off. Application of bandage contact lens at the end of procedure, which would stay there till the surface epithelializes, be it a month or a month and a half. And need for tarsorrhaphy in cases of poorly fitting BCLs in irregular corneal contour should be explained to the patient. So my experience in two case scenarios, one for cosmesis and other for cosmesis plus visual rehabilitation. This is a short video which I'll be. The indication is basically a leukomatous scar with BSK, where BSK removal done with diamond buckle knife followed by diamond burr polishing, cauterization of the blood vessels being performed. Followed by placing a drop of ink over the surface which was spread, and then the tattoo gun was used to make micro punctures in the cornea intrastomally, and covering the entire surface of the cornea till the limbus in the similar manner. The procedure is repeated multiple times after several washes being given till one is satisfied that the entire surface has a cosmetic acceptable outcome. The excess dye is removed after washes and with sponge. The complete surface is covered, and then at the end of procedure, after washing, a bandage contact lens is placed. So this is at the end of surgery. BCL was applied, and this is the post-op day 1 appearance. So the post-op medications would include antibiotics, steroids, and lubricants post-operatively. Drawbacks of this procedure can be in the form of discomfort and pain because of the epithelial involvement, and can result in PED till the epithelium heals in cases where the limbus is not healthy and the vascularization of the surface of the cornea is there, which impedes healing. And BCL stays till the epithelium heals. To conclude, tattoo gun helps us achieve. No, one video actually got skipped. I will just play. This is the second indication where it's used in case of a large failed graft, status post therapeutic penetrating keratoplasty, marking done with 7 and 8 mm trifines, and the dop of dye placed outside 8 mm to cover the rim which would be there as a white area outside the graft actually at a depth of 1 mm. So again in the similar manner, multiple intrastromal punctures are made outside the 8 mm marking that was done. This is repeated 3 to 4 times after multiple washes till a cosmetic acceptable dye we can see at the end. One has to be careful that the central area doesn't get covered with the dye, because intraocular penetration has to be avoided in any case because of the side effects of the dye. Flaringa ring is placed and a 7 mm trephination done, followed by a optical penetrating keratoplasty, and then sutured with 1610 nylon sutures. This is the post-op 1 day appearance, and at 5 months with a BCV of 6.9. This is a last video where we can see actually an area of thinning was there preoperatively, which was not very well delineated on ASOCT examination, and intraoperatively area of perforation was encountered, which we'll see after this wash. A gush of aqueous was seen. So this is just to state that one has to be very careful, and examination with ASOCT, the area should be demarcated before performing this procedure to avoid such complications. So to conclude, tattoo gun helps us achieve a better, consistent and uniform keratopigmentation results. So I would go on to my next talk, which is sure, sir.
Yeah.
I mean, bullous keratopathy.
Yeah.
Yeah. So naturally, it is understood the endothelium is damaged, isn't it?
Yes, sir.
After you put this, so again the patient will have corneal decomposition should continue.
No, he is talking about painful bullous keratopathy.
Yeah.
In non-seeing eyes, yes, sir, the endothelial dysfunction will persist. But since we are doing the microstromal puncture in the anterior stroma, the rate of bullae formation reduces.
This will go for scarring.
Yes, it goes for scarring. Yes.
So
But in the long run, we don't know whether, I think the bullae will form again because of the endothelial dysfunction. It might not be permanent.
the intention for you to putting BCL is just to allow the epithelium to grow.
Epithelium to heal.
Yes.
So that epithelium will again undergo bullous keratopathy because the endothelium is damaged.
Yeah, it might again form bullae actually, but BCL would just provide symptomatic relief from pain and discomfort to the patients.
It really does. I have done quite a good number of just puncturing bullous, and previous conception was discard, and there will be no further. But it doesn't really work that way.
Sir, we cannot hear you, sir.
So far the scar is concerned, this lamellar way that made by Aditya is very good, I feel.
Yeah, lamellar
But
pocket.
whole
Yes.
way in
The added
bullous
advantage is that epithelium is untouched, so no epithelial healing problems will be
Yeah,
there
yeah,
by his
that's it.
technique.
Anyway,
Okay, so I move on to my next presentation, which is the complications of corneal tattooing. The types of complications can be divided into organic and functional. This is again comes from one of the largest series by AIOC, which included 234 eyes of 204 patients, where complications were divided into organic, which included change in color, color fading, neovascularization, and functional, which included light sensitivity, visual field limitations, and MRI alterations. So organic complications, as we can see here, the tattoo dye has faded and there is vascularization of the cornea. This is by superficial technique, and the other slide shows by a lamellar technique. Light sensitivity, which is also one of the most common complications according to his series, where he had graded the light sensitivity reported by the patients from grade 0 to grade 4, and grade 4 is extremely incapacitating for the patients because they cannot bear any light, and it's difficult to open eyes even in daylight and indoors. Next is the MRI alterations, which is from the heavy metals such as iron found in tattoos, which can cause local magnetic field variations and cause distorted image of the globe. And this can be reported even 3 months after the keratopigmentation. Some of the rare complications can be also in the form of granulomatous keratitis, which is induced by multiple stromal punctures. One of the rare complications, very uncommon, is corneal melt. The risk factors being again the poor adherence of the epithelium at the areas where the pigments are injected, the failure of diffusion of nutrients from the aqueous humor, the increased levels of MMPs associated with increased inflammation, and the toxic effects on keratocytes leading to necrosis. The protective mechanism being the phagocytosis of the pigments by corneal fibroblasts, which leads to a more stable and permanent tattoo, as well as decreased inflammatory reaction. And this has also been demonstrated by the electron microscopic studies. TAS, which is one of the more rare complications, and this article stated a self-inflicted injury by a tattoo artist using copper pigmentation, which can mimic a TAS. The clinical features which were stated were severe corneal edema due to endothelitis, fibrinous AC reaction, ocular hypertension due to damage to the trabecular meshwork, associated with minimal pain and without vitreous involvement. These are some of the case descriptions from our institute. Case number 1, where we can see a failed vascularized graft, 41 years old female with hand movement, counting finger vision, was there in the this shown on the left hand side picture. Then the underwent tattooing, and visible fading was noted, as we can see here in this picture, when she presented at 2 months post tattooing, and there was a persistent healing defect, and because of the loss of BCL, the BCL fell off. So that is more important to continue to have BCL in place for the epithelium to heal quicker. So at 65 days post-op, we saw this corneal dense infiltrate, which was found to be fungal filaments on microbiological examination. Case number 2, which was shown, this was the patient where the video was shown, where we can see a leukomatous scar. An area of thinning on ASOCT was not delineated because of the presence of scar and fibroblasts. So this patient underwent tattooing, and we saw in the video that he encountered a perforation on table. This was a long-standing poor vision from childhood. The ASOCT actually falsely showed a Pachy to be more than 600 microns. This is the ASOCT of this patient. where we can see that this is after tattooing. So the underlying shadow defect is seen actually with a very thin layer of cornea seen. This case number 3, where it was performed in a staphylomatous eye along with BSK. So the cosmetic lens had failed to fit properly and the patient was keen for tattooing, but we see that the epithelium was non-healing post-operatively and there was a persistent epithelial defect. And at 2 months also again the patient presented with sudden pain and redness, and there was a near total defect in the eye. And on scraping, after scraping, the patient was started on empirical therapy as no organism were detected and culture was also negative. At 3 months follow-up, the PED didn't heal and the patient was taken up for tarsorrhaphy. So these are some of the pictures of complications from Dr. Kunjal. In the early post-op period, we can see a non-healing epithelial defect due to loss of tattoo dye, and BCL was placed and steroid drops were started. This is again another picture where corneal edema was induced because of the fixative toxicity, where hydrazine hydrate was used as a fixative. But this was managed by frequent topical steroids. One of the late post-operative picture where there was a focal epithelial defect which was managed by a bandage contact lens. Again a late post-operative picture where there was a loss of tattoo dye due to vascularization over the surface, and this is the post-op where the entire dye had faded. Loss of tattoo dye due to neovascularization, again we can see subsequent follow-up of patients from 21 to 24 where there is total loss of dye from the periphery. So the complication can vary from pigments in the conjunctiva to endothelium, pigments in the lens, vitreous cavity, secondary glaucoma, non-granulomatous uveitis, TAS, and even a corneal melt and carcinogenicity according to various literature search that we did. So it can vary to any extent. The basic idea is to choose an appropriate patient with appropriate dye to perform a good cosmetic outcome, to achieve a good cosmetic outcome. Thank you. These are my acknowledgements. Any questions to any of the speakers?
Yeah, ma'am, the slides which you showed in complications of the persistent epithelial defect, that was post-gun tattooing, ma'am?
Post-tattooing. So this is one of the most important feature actually. Post-tattooing, one should be very careful about the epithelial defect, and premature BCL removal should not be performed because that only leads to complications. And if one feels that the BCL is not going to stay because of the irregular globe contours, then a lateral tarsorrhaphy or a paramedian tarsorrhaphy can be done in such case scenarios, because epithelial healing is of utmost importance for the dye to stay back.
So most of these patients with scarred corneas and all, they have less corneal sensations. So any role we should check the sensations before or?
Yeah, definitely it can be checked because sensations would be less in viral status post-viral keratitis, or if it's a neurotrophic keratopathy in such case scenarios. So tarsorrhaphy should be advocated definitely. If we suspect preoperatively and if we know, we are aware, then tarsorrhaphy is the must in such case scenarios.
So all these dyes, do they sustain for a longer time or every dye fades? So what is the average time we should tell patient the dye will fade away?
Average time that we tell to patients in the liquid dye that we use is approximately 6 to 8 months it should stay. If the surface is appropriately healing, lack of vascularization, no epithelial defect, regular globe contours. Like if we select certain cases which are ideal case scenarios, then definitely it would stay for 8 to 10 months. But if these are like some of these high-risk cases like lots of vascularization over the surface or a staphylomatous eye, then those cases we have to be very careful.
I have seen that you have done peripheral tattooing in a case of graft.
Yes, sir. Actually, why I did that, because it was a large failed graft. It was a 10.5 mm graft which was done for a fungal keratitis. So the cosmetic appearance was a total white eye. So for the patient, even if we do optical penetrating keratoplasty, we cannot do a very large size for optical grafts to avoid risk of failure and rejections. So we can choose 7.5 or maximum 8 depending on how the condition is. And if we choose 7 or 8 mm graft and the opacity is extending till limbus means 10 or 10.5, then the periphery 2 mm will remain white. So that would give, which we all face actually in all large grafts that we do for therapeutic keratoplasty. So what I thought is if I can cover the 1.5 mm rim outside without causing damage to the 8 mm optical graft which I do, and without the pigments being going intraocularly, that was my basic aim to do this procedure actually. And I washed multiple times and ensured before performing a trephination of 8 mm that the surface is totally dry and the pigments are not becoming loose, and there was no chance of the pigments going inside the eye. So that has to be taken of like utmost important, because if it goes inside, it was inside reaction and the entire purpose would get defeated.
Excuse me, whenever a graft fails, major big graft fails, what we used to do a smaller graft so that the scar between the two grafts is to prevent the antibodies and something to come and again cause graft failure.
Yeah, that's what we cannot do large grafts.
Okay, but whenever you tattoo that area, you know, so the failure of graft is because of the limbal vascularization, which takes this antibody and all that to cause the graft failure. Isn't it?
Yeah, antigen antibody complex.
Antigen antibody complex. So if you put this tattooing, so you again initiate vascularization, isn't it?
Means you want to say that tattooing would incite vascularization,
Yes,
is it?
because it's a foreign body, it should.
That we are not, in the long run we can see, actually we cannot comment because I have not done too many. I have just done 2 procedures like this. And this was for the cosmetic appearance of the patient.
I had the privilege of doing keratoplasty for quite a long time. So I used to do a smaller graft whenever there was a failure for a large graft. Just with the scarring would prevent the antibodies and everything. But whenever you put this
Mike. माइक दूसरा दे दो ना सर को.
Hello?
Now you are audible.
So if you put graft again, and if you put tattooing in the peripheral part, so you incite vascularization, isn't it? Whatever it is a foreign body.
May insight, yes.
Yeah. So naturally you incite the graft failure, which is more important. Because inside, we intend to keep the graft alive rather than to go for this cosmetic purpose of the cosmetic. Yeah, because if you go for this, cosmetic purpose, if you go for the cosmetic blemish, then you incite vascularization, which is harmful for the graft.
So just a couple of points. The one that we are using commonly, the India ink, that is the non-metallic pigment. So it is a relatively inert pigment. It is a pigment. And secondly, the studies have demonstrated that it gets deposited inside the keratocytes, in the stroma. So it is not something which is in the extracellular matrix and inciting vascularization.
That what I was intended to know from Aditya. Have you got any cross-section, failure graft cross-section, a histological section, failure, then what is the endothelial damage, or what is the of endothelial penetration of the dye that you inject, intrastromal?
Cross section. Have you done histopathology?
Histopathology I have covered. Histopathologically, sir, it remains in the anterior stroma. The DM and the endothelium is not, it does not reach up till that level.
Its intake is by keratocytes, so
Remains in the
stromal layer.
Yeah. I think we can wrap up. Yeah. Can give the
So thank you so much for attending this session.